Hello, everybody. Today is going to be a small session on management of magnetic foreign body ingestion in the pediatric age group. Previously, we saw about button battery ingestion. So, this class is going to be on your magnetic foreign body. So, let's see. You will start with an introduction if such a question is asked in theory exams. Always try to make your theory exams as complete as possible. Your answer should look complete. It should have a small intro and small conclusion. The conclusion can be anything. It can be a prevention, it can be the prognosis, it can be the complications, but something. There should be a beginning, a body, and an end. So when a magnetic foreign body is asked, try not to directly jump to the management. Management is what you will be elaborating on, but try to give just one or two points on each of the following topics. So foreign body injection is will constitute anywhere between 3 to 5% of pediatric emergency visits. It's common in toddler age group. Toddler is 1 to 3 years. Okay, 1 to 3 years is toddler. If you are hearing some drilling sound in the background, I'm so sorry. I can't do anything about it. 1 to 3 years. Why is it common in the toddler age group? Because they are naturally curious people who try to go around and explore things, try to put everything in their mouth and find out through different senses, learn through different senses about each and everything. Plus, anything that is reachable to them, yes, goes in their mouth. Plus, the recent toys that we are seeing, electronic toys that we are seeing, have magnets that are of nice, sizable magnets that will go in their mouth. So, these are the reasons why magnet could be a common foreign body in children. Importance of magnet when it comes to us as people who manage the foreign body ingestion. You try to find out what sort of a magnet it is because neodymium magnets are notoriously more powerful. They are 5 times more attractive than your regular magnets. And always try to find out how many they have ingested, whether it was multiple magnets or single magnets, whether it was swallowed at the same time or sequentially. And try to find out whether it was just a single magnet at one point and later something else went in, like a metallic button, a screw, a pin. So even that will pose the same risk as multiple magnet ingestion. So why? Because of the mechanism of injury. The single magnet is going to act like any other foreign body. It is going to either pass through the system or get obstructed somewhere if it is going to be big enough. Multiple foreign bodies, multiple magnets or a magnet and a metallic object on the other hand, attracts each other. And when it attracts each other through two different bowel walls. So you have this bowel wall, you have this bowel wall, and there's a magnet here. They are going to attract each other, isn't it so? So this results in adhesion, adhesion of the two bowel walls. So when it is going to adhere to each other, it will impair the motility. When it impairs the motility, there can be twisting, there can be formation of closed loops. There can be interruption to blood supply resulting in ischemia, paralytic ileus like obstruction. Sometimes it can result in a volvulus like presentation also. On the other hand, the adhesion, when the walls are in close contact with each other, they can perforate through and it can result in a fistula formation. Okay, it can result in a fistula formation. The thing is, if you see the papers that have presented about magnetic foreign body, perforation, yes, has been reported, but more so often the perforation does not lead to a pneumoperitoneum or leakage of the abdominal contents in the peritoneal cavity. The reason being, even though it perforates, it generally adheres to each other. It's not open to the abdominal cavity. All right. So with this pathophysiology, what sort of complications could you expect? The complications that you will expect are enteroenteric fistula or a enterocolic fistula, depends on whichever bowels are in contact with each other. There can be peritonitis if it's going to be an open perforation. There can be bowel necrosis if ischemia is going to be too long, and it can peritonitis can lead to an intra-abdominal sepsis. So these are the common complications that you would expect depending on what sort of presentation the child is going to come to you with. Is it going to be a peritonitis perforation sort of presentation, or is it going to be an obstruction sort of a presentation? So in history, it's important for us to find out those things. What are you going to ask about? You are going to ask about how many were consumed, how was it consumed, was it consumed together, was it consumed sequentially? See, magnets consumed together, you know what happens? They adhere early on to each other. So less chance of two different bowel loops coming together and resulting in problems. But if it was consumed sequentially, one after the other, then the transit times are going to be different for both. Right? So there is a chance that these two magnets, which are moving at different paces in different places, can attract each other and result in problems. And how long ago was it consumed? Apart from that, you will ask for the consequence of the consumption. You were here asking about what happened before, then what happened after. Are there any signs of obstruction? Are there any signs of perforation? So signs of obstruction, perforation, all of you know. Obstruction, you will have abdominal distension, patient can have vomiting, bilious vomiting, patient can have obstipation, constipation. In perforation, patient will have a rigid abdomen, tense abdomen, patient will be sick if there is peritonitis, right? So you will write all those. So I will not be elaborating too much on that. But examination point of view, these two are very, very important. What investigations are you going to do? You will do a basic X-ray chest and abdomen. You will do a AP and lateral view. Again, what I see is I had the opportunity to look into some of the Xerox of answer sheets of students who sent it to me. What I noticed was you have written all the necessary points, but not elaborated on it. By elaboration, I do not mean writing paragraphs. So if I say investigation of magnetic foreign body, I will do X-ray chest and abdomen. I will do a point of care ultrasound. I am right, all right, but you want to let the examiner know what you are going to look for in that X-ray, look for in that ultrasound, isn't it so? So you should write at least one or two lines about what you are looking into it. Suppose, for example, a malaria question is asked. Investigation, I will do a thick smear, I will do a thin smear, I will do a antigen test, I will do. Yeah, understood. You will do all that. But what is it that you are looking for in those? That is important. Okay, so here in X-ray chest and abdomen, I am going to be looking for the number of foreign bodies. Why? Because one is safe, more than one is not safe. Location of foreign body, where is it? Is it in the same place? Is it adhere to each other? Is it in different places? Then you will be looking for signs of obstruction and perforation. What are the signs of obstruction in X-ray abdomen? You will look for distended bowel loops, too many gas shadows, which is not going to be progressive if you are doing a serial X-ray. Perforation, what you will be looking for? You will be looking for gas under the abdomen, at least one point. If not everything, you need not write football sign, you need not write in detail, but at least one point as to what is it that you're going to look for is important. Then in point of care ultrasound, focus is point of care ultrasound. So point of care ultrasound, what are you going to look at? First of all, you will use a probe that is having a high frequency. Then what are you going to look for? If it's a metallic foreign body, then it is going to give, shadows underneath that metallic object. Only if it is a metallic object, you will have those ring-like shadows. Otherwise, you will not. So this is about small investigation. Then treatment. Treatment wise depends on whether it's a single magnet consumption or it's a multiple magnet or single magnet with a metallic foreign object. All right. So single, see whether it is in the esophagus or stomach. If that is so, assess if the child is at further risk of ingestion of a foreign body. In that case, remove it. If not, you can do a serial X-ray and follow up as an outpatient. If you find that there is delayed progression, what did we talk about as delayed progression in the previous class? Let me see if you have listened to it. Let me know down in the comments or in our Telegram group, Pediatric Takes. All right. So, If it's going to be delayed, then you can use a laxative. Okay. If the child is at further risk of foreign body, remove it endoscopically. Simple. If it is beyond the stomach, see how far along is it. If it's in the proximal area, you can consider endoscopic removal. But if it's too, distal, then do a serial X-ray and follow up as OP patient. How to remember this? Simply, madam, this much and all I cannot remember for exams. I need simpler version, Naka. Then just write single foreign body. If the child is at risk for further foreign body, remove it. If the child is not at risk, do a serial X-ray, wherever it is. Alright, so that's more than enough. What about multiple magnets or a magnet with a foreign body? So, if the child has had multiple foreign bodies, multiple magnet conception, and it is in the esophagus or stomach, how long ago was it consumed? If it is less than 12 hours, then a gastroenterologist can remove it. If it's more than 12 hours, a gastroenterologist can remove it, but a pediatric surgeon should always be there because more than 12 hours it could have gone down below. And if there are complications, then you need a pediatric surgeon to open up through laparotomy, right? So less than 12 hours gastro, more than 12 hours gastro plus a pediatric surgeon. If it's going to be beyond stomach, if the magnetic foreign body has gone beyond stomach, multiple magnets has gone beyond stomach, then see if the child is symptomatic or asymptomatic. See, symptomatic, it is always going to be removal. So you need not break your head at all. If the child is symptomatic, with a pediatric surgeon, open up the abdomen and repair any damage that you see along with removal of foreign body. If the child is asymptomatic, you can still consider removal. Then depending upon where the position is, you can consider follow-up with a serial X-ray, but as inpatient. Alright. So, in a single magnet, you can do a serial X-ray as outpatient, but in a multiple magnet, serial X-ray should be done as an inpatient. Every 4 to 6 hours you will do if you have decided not to remove it. Then you will look for progression. If it is progressing, follow up. If it is non-progressing, then give a laxative, do a serial X-ray. If it is progressing, then follow up. If it is non-progressing, then you're going to remove it, obviously. That's all about management of your magnetic foreign body. Conclude with prevention. How are you going to prevent? You are going to prevent child size magnets in the child's area. Try to keep things out of reach. Preferably, magnet manufacturers should come out with larger size magnets that are not going to be consumed. And flux index, the attraction value of the magnet, should preferably be less than 50 kg square plus, how to tell this, 50 kg square, square. Yeah, so that should be the flux index of a magnet. So that will be nearly 37 times less powerful than your regular magnets and considerably reduce the complication rate. What else can be done in prevention? One more thing is make sure the child does not wear any, metallic seat belts, metallic chains, or shirt with metallic buttons because you do not want the magnet to come near the abdominal wall either. Right, it should not go too in also, it should not come too superficial also. You want it to go out. So this is about prevention. If you know this much about management of magnetic foreign body, it's enough to answer in your OSCEs and your theory exam. Hope this was useful to you. Share it among students who are going to exams or pediatric residents who will benefit from this lecture. Thank you all for listening to me. If you have any doubts, you can reach out to me in Pediatric Takes Telegram group. Thank you, bye bye, and all the best.